What if public health does not have an evidence problem? What if it has a movement problem? We have more health research, clinical guidelines, strategic plans, toolkits, and evidence-based interventions than at any point in history. We know tobacco use increases the risk of serious illness. We know physical activity is beneficial. We know social conditions shape health. We know prevention is usually cheaper than crisis response. The evidence exists. Yet, many communities still experience preventable illness, unequal access, and programs that disappear the moment grant funding ends. So maybe the problem is not that we need more evidence. Maybe the problem is that we have not built reliable systems for moving evidence into implementation, implementation into adoption, adoption into sustainability, and sustainability into measurable impact. Welcome to episode 26 of the Public Health Practice Gap. I am your host, Dr. Bradley Fevrier. This is the podcast that examines why public health solutions fail and how we redesign systems that actually improve population health. Today, I want to introduce a framework that helps public health professionals, healthcare leaders, universities, employers, and policymakers diagnose why a promising initiative isn't creating the results they expected. I call it the Public Health Practice Gap Framework, and it has 5 stages: evidence, implementation, adoption, sustainability, and impact. A program can be evidence-based and still fail. It can be well-funded and still fail. It can attract participants and still fail. It can run for years and still fail to produce meaningful health improvement. That's because public health activity is not the same as public health impact. Consider a hypothetical community organization that receives funding for a diabetes prevention initiative. The intervention is evidence-based. The organization hires qualified staff, builds attractive materials, creates a registration page, and promotes it through social media, flyers, emails, and community partners. It launches a schedule. On paper, everything looks successful. The grant was awarded, the staff were hired, the classes were offered, the reports were submitted. But only a small percentage of eligible residents participated. Several registered and never showed up. Others attended once and disappeared. Partners quietly stopped promoting it. When the grant ends, so does the program. Was it successful? The organization completed its activities. But did those activities improve population health? That's the distinction we keep failing to make. We count brochures, registrations, workshops, website visits, and social media impressions. Those numbers tell us whether work happened. They don't tell us whether health improved. An organization can produce a great deal of activity without creating meaningful change. Let's walk through the 5 stages. Evidence asks whether an intervention can work. Is there credible research behind it? Under what conditions did it work? An intervention that succeeded in a well-funded academic medical center with specialized staff and highly engaged participants will not automatically succeed in a rural community or an under-resourced school district. Evidence tells us something can work. It doesn't guarantee it will work everywhere and for everyone. Evidence without implementation is just an academic finding. Implementation asks whether the organization can actually deliver it. Enough trained staff, a realistic workflow, real leadership support. This is where good ideas collide with organizational reality. A hospital approves a patient navigation program but never integrates it into clinical workflow. A university buys a mental health platform, but nobody trains students on when or how to use it. An employer announces a wellness initiative, then schedules it when shift workers couldn't attend. The program exists on paper. The infrastructure to actually deliver it does not. Implementation without adoption is just an operational exercise. Adoption asks whether both the intended population and the staff delivering it will actually use it. This is the most underestimated stage in public health. We assume people will use a service simply because it exists. And when participation stays low, we blame the people. Unmotivated, disengaged, resistant. But adoption depends on trust, relevance, and real accessibility, time, location, language, cost, and transportation. It also depends on a psychological burden. Does participating mean disclosing something stigmatized? Repeating a painful story to 5 different people? Worrying that using a workplace mental health benefit will change how your manager sees you? Wondering whether a student counseling visit will stay confidential or somehow make its way back to a professor or a parent? A program can be evidence-based and well implemented by every internal metric and still be poorly designed for the actual humans it's asking to use it. When people don't show up, the first question should never be, what's wrong with them? It should be, what barriers did we build? Often without realizing it. Stop asking only whether you offered the program. Start asking whether people could realistically use it. Adoption without sustainability is just a temporary campaign. Sustainability asks whether the initiative survives after the funding, the publicity, or the funding champion moves on. So many public health programs are built as temporary projects for programs that are permanent. Grant arrives, temporary staff hired, program launches, data gets collected, final report gets submitted, funding ends. Staff leaves, program disappears. A year later, someone launches a nearly identical program under a new name, and the cycle repeats. That's the appearance of innovation without any durable infrastructure underneath. Real sustainability isn't hoping more funding shows up eventually. It requires actual planning. Is the program in the long-term budget, or is it always one grant cycle away from ending? Has it been built into normal operations, or does it live off the side as a side project or a special project? Are new employees actually trained to deliver it? Or does the knowledge live in one person's head? Can it survive that person leaving? A program that depends entirely on one grant, one champion, or one temporary team is not yet a sustainable system, no matter how well it is running today. Sustainability without impact is just an institutional habit. Impact asks the question that actually matters. Did this produce a meaningful, equitable improvement in health? Did outcomes change? Were disparities reduced? Or did the same people benefit who always benefit, while the people who needed it most stayed exactly where they started? A wellness program can rack up hundreds of registrations that are almost entirely people who are already active and engaged. A university can report thousands of visits to a mental health website, while the students with the greatest need are stuck on a wait list. A hospital can refer patients to community services and watch most of those referrals go nowhere because nobody solves transportation or scheduling. Every one of these organizations can report monthly activity. None of that is the same as impact. Here's why this framework matters. The 5 stages are connected, and a weakness anywhere breaks the whole chain. Evidence tells you if something can work. Implementation tells you if you can deliver it. Adoption tells you if people will use it. Sustainability tells you if it lasts. Impact tells you if it actually helped. Here are some quick examples. A university wants to improve student mental health. The evidence supports an early intervention and peer support. Implementation needs enough staff and clear referral paths so a struggling student doesn't fall through the cracks between departments. Adoption needs students to trust the service and genuinely understand confidentiality. not just read about it in a handbook. Sustainability needs a special, stable funding and reliable, real, institutional policy, not just enthusiasm from whoever happens to be running student affairs that year. And impact means actually checking whether students got timely care, whether crisis decreased, and whether the gap between the neediest student and everyone else actually narrowed. A hospital wants to cut readmissions. Evidence supports patient education and care navigation. Implementation needs the discharge team to have the time, the accurate information, and the clarity of responsibility to do it right, not just another task piled onto an already stretched shift. Adoption needs patients to actually understand instructions, obtain their medications, and make it to a follow-up, which assumes they have transportation and a schedule that allows it. Sustainability means this becomes standard workflow, not a pilot with an expiration date once the quality improvement grants run out. Impact means checking whether readmissions actually dropped and whether they drop for every patient population or just the easiest ones to reach. An employer launches workforce wellness. Evidence supports physical activity screenings and stress management. Implementation needs leadership support and protected time to participate, not just a company-wide email announcing it exists. Adoption needs employees to believe it's confidential, relevant, and worth their time, especially the employees who are most skeptical of anything coming from HR. Sustainability means it's baked into the benefits strategy and company culture, not a one-year pilot that quietly vanishes. Impact means checking participation across every job category and shift, not just the office staff who already had the most flexibility and were already the healthiest people in the building. Same framework, different setting every time. The specific program changes, the pathway from evidence to impact does not. Here's your practical challenge. Pick one program in your organization right now and run a 5-question practice gap audit. What's the evidence behind it? Can you actually implement it consistently? Will the people it's meant for and the staff delivering it really adopt it? Can it survive after the current funding or the current campaign is gone? And what evidence would actually prove it improved health equitably? Find your weakest stage. That's very likely the reason a genuinely good idea isn't creating real change. Public health leadership isn't measured by how many programs you launch. It's measured by whether those programs survive contact with the real world. A program manager asks whether the intervention launched. A systems leader asks whether it was adopted, sustained, and capable of actually improving population health. Evidence matters enormously, but evidence is the beginning of the journey, not the destination. The goal is building systems that make what works usable, accessible, sustainable, and effective in real people's lives. That's how we close the public health practice gap. For more systems analysis and implementation strategies, visit nextgenpublichealthconsultancy.com. Subscribe to NextGen Public Health Brief and check out my book, From Health Idea to Implementation. If this gave you a new way to look at your organization's programs, subscribe and share it with a colleague. Don't just ask whether your organization has a program. Ask whether the program has a realistic pathway to impact. I am Dr. Bradley Fevrier, and this has been the Public Health Practice Gap. Until the next time, let's keep building public health systems that work, not just on paper, but in practice. Not me. They say slow down, son, take your time.